So this is Dr. Jean Hubble from U.S. World Meds conducting a APOCIN in the treatment of motor fluctuations training session. On the first part of this call, with accompanying slides and video, we'll review Parkinson's disease and OFF episodes associated with levodopa use. And then we'll move into APOCIN, how it works for the treatment of OFF episodes, its potential side effects, and then APOCIN's use in clinical practice. Parkinson's disease is one of a group of movement disorders called Parkinsonism. Parkinsonism can be applied to any clinical situation in which a patient has tremor, usually with the hand at rest, increased muscle tone that's called muscle rigidity, and an overall slowness in body movement that's called bradykinesia. Parkinson's disease is the most common form of Parkinsonism, and it almost always responds to the medication levodopa. The cause of Parkinson's disease is not known. Both inherited and environmental factors have been implicated. Parkinson's disease is estimated to affect just under 1 million Americans. It's the second common neurodegenerative disorders, with Alzheimer's being the most common neurodegenerative disease in the United States. We often say that Parkinson's affects about 1% of the U.S. population that's above age 65. Its occurrence certainly does increase with advancing age. It's rare to be able to diagnose Parkinson's before the age of 20. We call young onset Parkinson's disease Parkinson's symptoms that begin before age 40. But then the incidence and prevalence goes up very steeply after age 60. Men are a bit more often affected as compared to women, which is the reverse of Alzheimer's disease, which most often affects women. It's estimated to cost the U.S. economy about $14 billion per year. And some would say when you assimilate the indirect cost, that it's a much higher socioeconomic burden. Parkinson's in the brain causes a change in a group of brain cells that usually produce and transmit a chemical signal called dopamine. So it's the loss of dopamine within a certain region of the brain that's responsible for most of the motor symptoms of Parkinson's disease. By motor symptoms, I mean tremor, slowness in movement, and muscle rigidity. Parkinson's disease, though, can also cause non-motor symptoms. They're not as well understood. Those can include depression, anxiety, pain syndromes, and autonomic nervous system dysfunction. Those other non-motor symptoms do not respond to levodopa or other dopaminergic replacement therapies. Levodopa was introduced for the treatment of Parkinson's disease in about 1968, and it remains the mainstay of Parkinson's disease therapy. Its precursor treatment, levodopa, is absorbed in pills through the gut, crosses the blood-brain barrier, and within the brain it's converted into dopamine, which again is that missing signal in the brain of a Parkinson's disease patient. Dopamine itself cannot be absorbed in the gut and does not cross the blood-brain barrier, so we can't give dopamine itself to replenish the missing dopamine in Parkinson's disease patients. When levodopa is first started in the treatment of Parkinson's disease, the robust is very typical with a marked reduction in motor symptoms. However, non-motor symptoms like depression, anxiety, autonomic nervous system dysfunction are refractory to levodopa. I'm going to briefly show a videotape made back in the late 1960s of a patient before he goes on to levodopa therapy and then as he begins levodopa therapy. As the tape runs, we'll see that the patient is attempting to arise from a chair, but he's so slow and stiff in his movements that he cannot arise without assistance. As he is helped to a standing position by the medical student, we start to see the tremor more noticeable in his right hand as compared to the left. Once he stands, he has a very stooped forward-leaning posture. He has very poor balance, and he takes little stooped steps. His wife is shown in the videotape, and she's learned various maneuvers to help him walk and maintain his balance. It shows then a close-up of the patient's hands, noticing that the tremor is much more prevalent on one side than the other. That's typical for Parkinson's disease. It tends to affect one side of the body more than the other. He also will be asked to make rapid alternating movements of the hands, finger taps, as widely and quickly as he can, but he can barely initiate those movements, particularly with the right hand. So he has very reduced dexterity, much more so on the right than the left, typical of Parkinson's disease. In a moment, the video will show his face, and he has jaw tremor. He also has very reduced blink rate, and again, that gives that very masked or still appearance to the face of a Parkinson patient. Then we move to the same patient just 2 weeks later when he's now on levodopa therapy. And it shows him easily standing from a seated position without any difficulty at all. And he can easily walk without any assistance. He still has some tremor in the right hand, so the levodopa has not alleviated 100% of his motor symptoms. But nevertheless, it's made a very dramatic change in his ability to stand, walk, and make rapid alternating hand movements or improve his dexterity. So in seeing this videotape, I hope you can understand that when it was first introduced in the late 1960s, early 1970s, levodopa was actually called the Lazarus drug because Parkinson patients who were nearly bedfast were able to get up and walk, move, speak, and resume most of their normal volitional movements. Levodopa is not a cure for Parkinson's disease. It's what we call a symptomatic therapy, meaning it temporarily replaces or replenishes dopamine within the brain, but doesn't actually fix the underlying pathology within the brain of a Parkinson's patient. So it simply masks the symptoms by temporarily replenishing dopamine. So that's the good news about levodopa. It's a very robust therapy for the treatment of Parkinson's disease. But motor complications over time limit its successful use. Motor complications are a major source of disability. They're particularly common in younger onset patients with long-term levodopa use. They take really two forms, sometimes when there's too much levodopa or dopamine within the brain, patient will have involuntary movements. We call those dyskinesia. Again, that coincides with the peak dose effects of levodopa or other dopaminergic drugs. So when you see Michael J. Fox on television, you'll usually see him having these kind of wiggly movements. That's not his Parkinson's disease. That's the side effects of his levodopa medication. The other problem with long-term levodopa use are motor fluctuations or off episodes, and that's what we'll focus on. We know that with long-term levodopa use, off episodes occur in the majority of patients, and again, that's particularly common in the younger onset patient. So an individual like Michael J. Fox, who is said to develop Parkinson's symptoms in his late 20s, once he started levodopa therapy, he was almost assured to develop this fluctuating response over time. We understand partially what causes these fluctuating responses to levodopa. We know it's in part because levodopa has a very short plasma half-life. It's a very short-acting drug. Even the longer formulations, newer formulations of levodopa have a relatively short half-life, so that there is no single dose per day available for levodopa dosing. We also know that the GI function changes in Parkinson's disease patients. They have delayed gastric emptying and very slow GI motility. Levodopa is an amino acid, and it's only absorbed in a very small portion of the duodenum, and therefore it has very limited bioavailability. So to put it in other words, every tablet of levodopa that an advancing Parkinson patient takes depends on just the right acidic pH of the stomach. It depends on relatively quick gastric emptying so that then that dissolved levodopa tablet can be absorbed in the small intestine. Otherwise, that dose has only a partial effect or no effect at all. The next chart shows an example of this pharmacokinetic profile in a fluctuating patient with Parkinson's disease taking levodopa. This patient's taking 5 levodopa-containing tablets per day. Levodopa in the United States is nearly always given with another helper drug called carbidopa. Carbidopa helps improve slightly these bioavailability issues. So in other words, carbidopa doesn't work against Parkinson's disease itself. It merely boosts the effects of levodopa. There's many brand names for levodopa in the United States. That includes the brand names Cinemet, Stalevo, Parcopa, and recently released Rotari. In this example, this patient's taking levodopa 5 times a day, and he's having his blood tested and measured for levodopa in the plasma hourly, starting at 7 a.m., and then he takes a tablet about every 2.5 hours. He starts the day at 7 a.m., and with that tablet of levodopa, carbidopa, there is no appearance of levodopa in his bloodstream. So he failed to absorb that tablet. So he stays in a very off position. In other words, he has very prominent Parkinson's symptoms. And so if he had tremor, his tremor would be very strong. He would have difficulty getting up and moving about. He may have very low, soft speech. Very much like when you see Muhammad Ali in recent televised appearances. He manifests off episodes almost always when he's on television. In this particular patient, he takes a second dose at about 9:30 a.m., and then you see a big spike in his bloodstream, and he switches on, but only for about a couple of hours, and then because it's such a short-acting drug, the levodopa then is removed from his system, including his brain, and he turns back off again. Takes another dose, has another short on period, turns off again, 2:30 in the afternoon. He takes a dose, and that only partially turns him on, and then finally he has a big spike in the bloodstream, and he turns back on later in the day with his final dose at 5 p.m. So it's this roller coaster ride with the levodopa that causes this variable response where a patient has off episodes or partial ons, delayed ons, and sometimes flat-out dose failures. Also, sometimes with the very peak effects of levodopa in the brain, the patient will get dyskinesias. This next video shows a patient in her kitchen who's having dyskinesias, and it shows her struggling to attempt to start to put together the family dinner, getting utensils out of the drawer and trying to make a way about the kitchen. Again, this looks a lot like when you see Michael J. Fox in his involuntary movements, but simply much more severe. This, again, is not the underlying effects of her Parkinson's disease. This is due to this erratic effects of levodopa in her brain, so that now she has too much levodopa and her brain is being overstimulated. So with the passage of time, these motor fluctuations, these on and off episodes become so severe that the patient has very little good motor function left. Now we're going to move on to the role of Apokyn in the treatment of these motor fluctuations or so-called off episodes. Again, there's a few different types of off episodes, but off episodes, again, are associated with levodopa not effectively working for those minutes or hours in time. That can happen at the end of a dose of levodopa, where a patient would typically expect to stay on and have good effects of a dose for maybe 3-4 hours, but they suddenly find themselves turning back off in 2 or 3 hours. Sometimes those off episodes can occur very suddenly. For patients with these off episodes, they frequently awaken in the morning and find their Parkinson's symptoms to be quite severe, where they're very off, have very manifest Parkinson's symptoms. They take their usual dose of levodopa and other Parkinson medicines, but they have to wait many minutes, sometimes an hour, or sometimes they even have a dose failure, so they just have to remain in bed or with very poor motor function until the next dose finally kicks in. Then there's delayed ons, where a patient sometimes turns on in 30 minutes with a dose of levodopa. The next dose may take an hour or an hour and a half. Some patients will have times where they have a suboptimal on. It's like they turn on 50%, but not 100%. There are other conventional medications, both pills and a Parkinson's disease medication skin patch. There are conventional medications that are approved by the FDA to help manage these off episodes. All of these drugs do reduce the total amount of off time during the waking day, and this has been demonstrated in studies. But all of these helper medicines, while they improve these on and off episodes, none of them totally abolish all off episodes. So that leads us to Apokyn. Apokyn's generic name is apomorphine. This slide shows that apomorphine at the very top of the chemical chart looks the most like dopamine of all of the available dopaminergic drugs. So the other drugs around the outside of the circle are other dopamine agonists that have been approved for the treatment of Parkinson's disease over the years, but it's only apomorphine that can really mimic that levodopa or dopamine-like effect. Apokyn is a auto-injector. Apokyn, despite its name of apomorphine, is not a narcotic. It is chemically related to morphine, but it has no narcotic properties. Therefore, it is not a scheduled medication. It is related to other available Parkinson's disease drugs, but it is the only one that can provide a true levodopa-like effect once motor fluctuations start. It is only administered subcutaneously. It's never given orally nor intravenously. In essence, it's injected much like insulin subcutaneous shots. Outside the United States, apomorphine subcutaneously delivered for off episodes has been available for many years in 2 delivery systems, both the auto-injector like we have in the U.S. and also a subcutaneous infusion pump. The pump infusion system is not yet available in the U.S. Apokyn has a specific FDA indication. It is only indicated for acute intermittent treatment of off episodes once a Parkinson patient develops these fluctuating responses to levodopa. The next video shows a younger Parkinson patient than we saw in the previous video. She developed Parkinson's disease in her 30s, and about 2 years into levodopa treatment, she began to develop a very severe fluctuating response where she'd have these off episodes that she could not manage by adjusting her Parkinson medications nor adding other Parkinson medicines. It shows her in a seated position with very severe tremor. In order to facilitate this taping before she gives her Apokyn injection, she purposely withheld her last dose of levodopa so we could film her in an off episode. Shows prominent tremor, greater on the right than the left. She is being instructed to lift her left arm and perform rapid alternating hand movements, but she can barely lift her left arm and cannot perform finger taps, and she cannot perform any movements, meaningful movements, with her right arm. She cannot stand nor walk without two-person assistance when she's in a total off state. She now is being given an Apokyn injection at her usual dose of 0.4 milliliters, and then it shows her 4 minutes later after the injection. Her tremor is greatly reduced. She's easily able to lift both arms and perform rapid alternating hand movements and other movements that assess her dexterity. In a moment in the film, we'll see that she's easily able.
Now what?
Jean? I can't
Hello?
hear Jean anymore. Hello?
Yeah, I'm
think we
still
lost-
on, but I think we lost Jean.
I think we
Yeah,
lost
I
Jean.
don't- Hello?
I think Cindy, are you going to let Jean know?